So do we have the slides? Yeah. So let me once again welcome you 101 episode of Thursday Musings, applying trauma-informed lens in everyday clinical practice. Next slide, please. I'm handing over the session to Professor Dr. Tufan Pati sir. Sir is from Cuttack. We have completed 100 episodes under his chairmanship. So over to you, sir, for carrying the program further.
Thank you. Thank you, Alim. Dr. Alim Siddiqui is beginning this 101st episode. Just take it as the beginning of the second century. Second century started, and we have got a good company and vibrant participation of Dr. Alim Siddiqui and Dr. Amrit Pattojoshi, professors of psychiatry in respective colleges. Dr. Alim Siddiqui is the treasurer for IPS, and Dr. Amrit Pattojoshi is a member of Executive Committee of Indian Psychiatric Society. So with this vibrant young moderators and participants, and who has been from the very outset of the conceptualization, I welcome you both to this beginning of the second century. And next slide, please. Next, please. Our chairpersons, Dr. Satish Rasili from Gangtok. He is consultant HOD at the Center for Addiction Medicine, Sikkim. He is MD Psychiatry from RIMS, Impal, postdoctoral fellowship in addiction medicine from NIMHANS, Bangalore. He is the nodal officer of drug treatment clinic and OST program, East Sikkim. He launched Gramin Manasik Swasthya Vision to take mental health and drug de-addiction services to rural areas. Conducted more than 1,700 awareness and sensitization programs between 2013 to 2019 to address mental health, stigma, drug addiction, and suicide prevention in the state of Sikkim. Imparted training to all 666 ASAs, accredited social health activists of Sikkim, on mental health, suicide, and drug addiction. Between 2013 and 19, he is so active in community psychiatry, he is so active in his contribution to the society. His areas of interest is addiction, psychiatry, suicide prevention, and community mental health. He received the IMA N. Ramchandran Murthy Award in Psychiatry in 2018. And above everything, Dr. Satish Rasili, suffering from COVID and is in isolation, and he is with us. Welcome, Dr. Satish. Next slide, please. Dr. Tushar Jagawat. Next slide, please. Dr. Tushar Jagawat from Jaipur. He is a senior professor and head Department of Psychiatry of NIMS, NIMS University Medical College and Hospital, Jaipur. He has 20 years of teaching, research, and clinical experience. He is past president of Indian Psychiatric Society North Zone, past president of Indian Psychiatric Society Rajasthan Chapter, past president of Delhi Psychiatric Society. Written Hindi poetry books related to mental health, psychiatry, and addiction. Mananjali, a book published in 2020, contains 100 poems related to COVID and mental health and other socio-cultural issues. More than 20 research publications in national and international index journals. His areas of interest are social psychiatry and community psychiatry, and he's also a vibrant and well-known personality in Indian Psychiatric Society. Welcome, Dr. Jagawat. And now onwards, the meeting is handed over to the chairpersons, Dr. Jagawat and Dr. Rasili. Please take over and carry on the meetings.
Good evening, everyone, everybody. Am I audible?
Yes.
Yeah. Thank you very much, sir, for your kind introduction and giving us opportunity to participate in one of the best scientific webinar series of, I think it is of the world, not in India. It is of the world, because this 100, there's just completed 100, and we are lucky that I am part of the 101, this webinar series. So I'm really thankful to Dr. Tufan Pati sir, Dr. Alim, and Dr. Amrit for conducting these excellent scientific activity to our society. Today, I'm really honored and delighted to be part of this webinar or this Thursday Musings. That is a part of this master classes on therapeutics in psychiatry. So very important web series. I would like to start my before the introduction of this our speaker, just a few lines in Hindi poetry to related to our trauma and therapy, especially trauma therapy or psychotherapy, whatever. So I would like to say that Chinta Chita Saman hai, that we all everybody knows. Chinta Chita ke saman hai, and the therapy is Gita Saman hai. The counseling therapy is like a Gita. The tension is injurious to health. A therapy a day keeps stress away. So that is very important, and everything related to the mind. So मन ही मन को जानता, मन की मन से प्रीत, मन ही मनमानी करे, मन ही मन का मीत, मन झूमे मन बावरा, मन की अद्भुत रीत, मन के हारे हार है, मन के जीते जीत, मन के हारे हार है, मन के जीते जीत. So we know that strong counseling, psychotherapy, supportive therapy has a very important role in trauma victims and stress victims, because so nowadays we have suffered for especially last 2-3 years COVID stress were there, and war is also there. We have seen so many wars, trauma. So this trauma is a very important part of our life day by day, or unwillingly this is coming to life of our in our life. So this is very important. So I'm really thankful and congratulations to the organizer for giving this excellent, very useful topic they have chosen for today's presentation. Because this acute stress reaction, we know because of trauma, post-traumatic stress disorder is there, adjustment disorders, dissociative disorders, acute and transient psychotic disorders, at times somatic symptoms or psychosomatic symptoms like irritable bowel syndrome and hypochondriasis, somatization, depersonalization, derealization. So many things, medical or psychological, emotional or spiritual level, we are suffering, the people who have suffered the significant trauma or disaster. So it is very, very important to give them timely intervention, the crisis therapy, or there are so many therapies that is useful. One of the most important therapy we'll discuss today is trauma therapy. So I invite Dr. Salini Anant. She is MPhil and PhD clinical psychology from NIMHANS, Bangalore. She has been practicing psychotherapy since 1993 after her post-graduation from Delhi University. She has taught in Delhi University, Tata Institute of Social Science, Christ University, and Manford College at various levels from UG to PhD. For the last 7 to 8 years, she has been learning and practicing trauma therapy. She feels passionate about orienting mental health professionals to the trauma-informed lens in working with various physical, somatic, and mental health concerns. She has independently conducted training programs in the same for about 200 fellow mental health professionals. So we are lucky to have such a senior, experienced dignitary and speaker. So I invite Dr. Shalini Anand to deliberate her very important topic to the august audience. Thank you very much to all.
Dr. Satish, please have your comments before we start. And please, Shreya, please stop sharing the screen. Your comments, please, Dr. Satish. Introduction about the topic, yeah. You are muted. Please unmute yourself.
Good evening, everyone. Thank you for inviting me in this 101 Thursday meeting. Though I am suffering from COVID, I accepted the invitations because like it was a privilege like to be invited by the Dr. Tufan Pati, Dr. Alim, and Orissa branch. like what I like, I was also thinking why why you have choose me to be as a chairperson today, because I come from a very different background. I have done most of the work in community psychiatry and addiction psychiatry, but yes, I do feel that like nowadays, due to increase like the pandemic, due to the arrival of the pandemic, uh, not only all of us are facing lots of trauma due to, I also feel now, since I have like traumatic experience, we are like facing traumatic experience uh, amidst a pandemic. The trauma can be due to like separations from family members, separation from like emotional and emotional separation from everyone. Also, the trauma of being separated from family while undergoing treatment for COVID, the trauma of like losing someone due to COVID. So, so like I think nowadays the stress and trauma has become important part and parcel of our life. So it is very important that we need to develop skills. We need to also learn skills from the learned experts from the field regarding trauma therapy. So we have read especially Saurabh has mentioned that like we also like I feel that during my clinical practice also, like when I go deep into the like history taking, like so many patients have traumatic childhood very bad traumatic childhood experiences, and still most of the of us psychiatrists, we try to look only at the precipitating, like the precipitating factors, the triggering factors. We like due to the time constraint, we never dig deep into the patient's history. We never go to the go into the depth. So sometimes, like especially the illness such as neurotic disorders, they have this trauma can be an underlying factor in causation of so many mental illness, including depression, anxiety, even addiction. So I feel that this particular session will be very fruitful to all of us. So I uh, like thank the organizing committee for especially like including this traumatic therapy in this Thursday meeting. Thank you very much, everyone. Over to Dr. Salini Anand.
Thank you, Dr. Satish, and everybody for the kind words. So today what we will do is, I believe that this forum has had a couple of lectures on trauma therapy, and today we will try to do a demonstration. I will speak for just 2-3 minutes before doing the demonstration, just to very briefly summarize what you have already learned, but just to also set the tone. So when we are working with trauma, there are a few things which we need to keep in mind. One is the neurobiology, which you have learned, I think, in detail about. So we understand the brain has different parts, multiple parts, and 2 lobes, and billions of neurons and trillions of connections. But the brain is sometimes very easily understood as having just 3 parts: the higher brain, the middle brain, and the lower brain. The higher brain is also called the thinking brain, which is mainly our frontal lobe and cerebral cortex. And the middle brain is mostly the limbic brain or the emotional brain, or also called the mammalian brain. And the lower part of the brain is called the survival brain or reptilian brain. What we must understand is that the trauma resides in the lower 2 parts of the brain, which put together are also called the survival brain, because the higher parts of the brain develop much later, and most of the trauma that happens in childhood, while these the lower parts are already there. So when we understand that, that is what helps us also understand using the methods which are more amenable to healing the deeper structures of the lower parts of the brain rather than talking. So using language is discouraged in doing trauma therapy, and using methods which would be healing to the lower parts of the brain are more helpful. This is one thing to understand. Another part to understand in neurobiology is that we understand the role of epigenetics. That while we are also all aware of genetics, the role of genetics and then nature and nurture, but even genes, the way they get manifested, the way they express that gets modified through our early childhood experiences, and epigenetics play a very important role. Sometimes it is claimed that they play more important a role than genetics. So, which also is a hopeful thing. So, which is why we do trauma therapy. So, it's not just a sad thing that things have affected so badly in childhood that genetic expression has changed. But there's also hope that if we do the right things now, genetic expression can also change for the better. The other, so one is broadly neurobiology we need to believe in. The second broad thing that we need to understand is attachment. So attachment theory given by Bowlby and then worked further on by Mary Main and Mary Ainsworth. All of us are mostly aware of that. But attachment is something which is extremely important to understand when we are working with trauma, because again, we pay much more attention to the experiences that have happened in childhood. It's a myth that the recent experiences will have more of an effect. Of course, they would be more fresh in the memory of the person, but the deeper impact is always created by the early childhood experiences because the brain is still developing. We very often use the example of Chinese foot binding technique. When a Chinese little girl is very small, her foot is bound very tightly because there's a cultural belief that small feet are considered beautiful among Chinese girls. Now, after she becomes an adult, even if the foot binding is opened, it's not that the foot will become of the normal size of an adult woman. So that is one of the examples that we use. Sometimes we even give such examples to clients, that experiences which have happened in our childhood, they affect our brain development because the brain is still developing and certain experiences would thwart the healthy development of the brain. So attachment experiences, we all know that the healthy attachment style is secure attachment style. And the three other insecure attachment styles are avoidant, preoccupied, and disorganized. So when any experiences which have happened multiple times in a child's life, even when we are seeing an adult client, in their childhood, when multiple experiences have happened because of which their attachment style has not been a secure type of attachment, that is what we are trying to heal in trauma therapy through very small droplets of methods, but slowly but surely, we try to keep moving towards an earned secure attachment style, even if the attachment was insecure in the beginning. So first broad thing we need to understand is neurobiology. The second broad thing we need to understand is the role of attachment, early childhood experiences. And the third thing which we very importantly understand is that dissociation is extremely common. When we are taught that dissociative disorders are very rare, especially DID is very rare. Of course, it's much less frequent than things like anxiety and depression. But dissociation per se is not as infrequent as we sometimes believe. In fact, if we remember the first rank symptoms, which we have all memorized, 11 first rank symptoms, they are more common in dissociation than in even psychosis. So there is no trauma without dissociation, because when trauma happens, the way we still keep going on in our life, we try to keep living our life, that is possible through dissociation. So it's a very unconscious process, but we try to cut that off from our memory or our experience. There are different ways in which dissociation can be understood, but a trauma therapist believes that dissociation is very highly prevalent. And we also work towards healing dissociation slowly, which is called integration. So we work towards integration. So that is the third broad thing that we need to remember, and trauma therapy will work towards that. The fourth broad thing is the principles of trauma therapy, and safety is one most important principle. So which links to our ethics that we know of beneficence and non-maleficence, do good and do no harm. So whatever we are doing in therapy, it should we have to first and foremost ensure that the person is feeling safe in the session, and which may or may not be, if they are feeling unsafe, it may or may not be because of us, but still it is our duty to ensure that they are feeling safe. Okay, so And also we understand the very high prevalence of trauma. We do not think trauma is one of rare thing, only some very rare people have trauma. There are now more and more acknowledgements, even by medical professionals. There are TED Talks by Nadine Burke, etc., who talk about very high prevalence of trauma, even among patients who show up with physical disorders. And trauma therapists go to the extent of saying that there is no addiction without trauma. There is probably no chronic physical illness without trauma, okay, without psychological trauma. So some of the simple methods that we all can start using is, one is the ACEs scale, which has just 10 items, and there are many other scales which we can use. Another principle to remember is that stress is not equal to trauma, but trauma principles help in healing mostly everything if we use the principles correctly. So what we will try to do is, we will try to do a very small demo. We have a volunteer here, Ashwati. I request the organizers to please put her also on spotlight. Ashwati, can you just wave your hands? Yeah. So Ashwati is going to play the role of one of her clients, but we will partly fictionalize it. And we will not do the whole case, which is not possible in such a short time span. But we will try to just see a few things that we do slightly differently in trauma therapy, rather than we might do in other settings. Okay. So Ashwati is playing the role of a client, Nancy, and we are trying to play act the 6th session. Okay, so we've had 5 sessions, and we will, so I, as the therapist, will just try to, so we are just starting with the 6th session. There's no particular reason, but just so that we have some amount of summary about the client. So, hi, Nancy.
Hello, ma'am.
Could you be slightly louder, please, so everyone can hear?
This is okay.
Yeah, could you please sit relaxed? So is it possible to just pin it in a way that, yeah. Can everyone hear Ashwati? Hear her, Ashwati? Dr.
Yeah,
Ali?
Yeah, we can hear it.
Yeah, okay.
I'm audible?
Yeah. Hi, Nancy.
Hello, ma'am.
Today we are meeting for our 6th session. And what you've told me is that you're about 40 years old, and you've told me some of the current difficulties that you have been facing. Okay. We are not going into that. I will summarize later, but okay. So have you been sleeping fine?
Well, a little bit with the medication, a little bit, but I don't think I've slept peacefully in a couple of months, you know,
Okay.
since all the stressful things have happened, since all the fights at home. Yeah, I have been having disturbed sleep. It's difficult for me to fall asleep. And then I sort of sleep a little, you know, into the morning also. And that kind of makes everyone angry at home. So yeah, all of this.
So you're saying that it's difficult to first fall asleep, and then it becomes difficult to wake up in the mornings.
Yeah, yeah.
Okay, so so here I might, so I'm just talking to the audience here. So here I might just do some sleep hygiene work. I might go into that, but that I will not demonstrate. Everyone knows that. But one point that I can make here is that trauma therapy is done in 3 phases. So the first phase is stabilization phase. The second phase is trauma processing phase. And the third phase is integration and termination. As part of the first phase, stabilization phase, we would ensure that the client is sleeping well. You know, the basics are in place, like the first rung of Maslow's hierarchy. They're eating well, they're sleeping well, they're overall physically fine. So let's assume we have done some amount of sleep hygiene, etc. Okay. So you were saying, Nancy, that you have been feeling a bit insecure right now because ever since you found out that your husband has been probably meeting someone else, right?
Right. Yeah. That was really, it really shook me up. Yeah, I've not been doing too well after that.
Finding it out has been really disturbing.
Yeah.
Yeah. So you also told me that you were really looking up to your husband in the beginning of the marriage. You almost saw him as a father figure because you have not felt that kind of safety and protection with your father.
Yeah, absolutely.
Okay. So I want to ask you something slightly different from what I may have asked you so far. And this is not directly related to your marriage or your husband. But can you think of any one situation in your life, ever in your life, in the 40 years of your life, maybe even for a moment, when you felt safe? You can take a minute or so if you want and think of any time when you felt even slightly safe. It may be in one particular place, it may be in the presence of one particular person,
Hmm.
maybe in any situation, it may be while doing a particular activity or anything.
Yeah, I think over the past few years, one thing the only thing that's helped me feel a little calm or anything is praying. Uh,
Praying.
when
Okay.
I pray, I feel a little bit, lighter.
Like, can you imagine as if you are praying right now? And can you notice where you feel lighter in the body?
I feel lighter in my chest,
Mhm.
in my shoulders. It's becoming easier to breathe.
I mean, easier to breathe. Can you stay with that feeling, lighter feeling in your chest and shoulders and the ease of breathing that you're feeling? About a minute or so and stay connected to that feeling. Let whatever happens, happen. Keep noticing. And rest your hand and be more relaxed, noticing it. If you could keep observing the sensation as vividly as possible, as if we were observing an object with all its physical properties, its color, shape, size, texture, weight, movement, sound, any property that we observe with an object. You keep observing and allow the sensation to be as vividly as possible as you can observe. And take your time, stay with the sensation, and then come back here with me whenever. What are you noticing right now?
Yeah. When you kind of asked me to notice the calmness, the properties of it, somehow just this image of probably maybe smoke, or something like breath that just moves, or air, something very light, maybe from a candle or something like that. Those kind of images just popped up, and I could sort of feel that it was spreading through my arms. Yeah.
Okay, so it felt like that sensation was kind of spreading.
Yeah.
Okay. Is there any name or a word that you would like to give to this sensation, just to remember it?
Flow.
Flow. Okay. All right. So just pausing here a little bit. So what we did is a very little bit of somatic experiencing. That is one type of trauma therapy. In that, one of the techniques is called resourcing, somatic resourcing. So we just did that. So we speak very little in doing the processing. We didn't even do the processing, but the trauma work is done with very little talk. So most of us who are trained mental health professionals, we are very used to talking a lot in the sessions. But in trauma therapy, we talk very little. So we do talk. I mean, we have to access things also. For that, we'll start with some amount of talking, but we don't rely entirely on talking, which is what we do in most of the other kinds of therapies. Okay, so this is one of the techniques. So now if she has a word also, sometimes clients may not have a word for that, which is okay. But, so we could go on to ask her, what color did you notice? What shape, what everything. We can ask all the physical properties. Just to save time, what I might do right now is, okay, back to you, Nancy. So you are able to use the word flow with this. Okay. Is there any color that you would associate with this feeling of flow?
Just the image that came to my mind was just white.
White. Okay.
Yeah.
All right. So can we do a little more of this staying in touch with this? So I will not do it, but maybe I will just explain to everyone. We could do one more set that we ask her to imagine that this white light is all around her, white flow is all around her also, and that she's able to breathe and it's entering into her in the other parts of the body also, through all the pores, through nose, eyes, ears, mouth, everywhere. So it is coming inside her and she can access that more and more. And so we may do one whole session on resourcing. Okay, so that's just one of the ways resourcing can be done. But let me show another technique now. So Nancy, if you've also been telling me that you feel slightly insecure, you don't know what will happen right now with the situation happening. So if you notice this feeling of insecurity, can you scan your body and tell me where you notice any?
I mean, just something from my stomach just pulling me down.
From your stomach, it seems like something is pulling it down. Okay. On a scale of 0 to 10, if 10 is the most disturbing and 0 is not at all disturbing, how disturbing is this sensation for you right now?
7.
Okay. Now, you could keep maybe one hand or both the hands on the sensation if you like, just to stay connected to it. And imagine that you have like a volume button through which you can increase or decrease the sensation. You choose the number to which you want to take it, and maybe only a little bit we can increase or decrease it. Maybe make it 6.5 or 6, or you can even go up to 7.5 or 8. Breathing.
I don't want to increase it.
Okay, so you can decrease it if you want. The volume button is in your control. You can do what you want.
I want to make it a 0, but I don't
Okay.
think it will do that.
All right. Now let's do something, another third technique. So what we will do, Nancy, is can I ask you to notice for one breath, the flow. For second breath, notice the sensation in the stomach. So one breath flow, next breath, this sensation in the stomach. Just keep doing alternate breath awareness. Do it calmly, there's no hurry. Your time. You can come back here to us whenever you want. What are you noticing right now?
I think when I did the first focusing on the flow, it was really relaxing throughout my body. But then when I began to notice that tension, like there was something that just kept pushing me away. I didn't want to do that. But it was also quite, I've not felt it this way before, but it felt a little secure or nice to know that I can go back to that feeling, that flow also. And so when I kept doing that, gradually that tension kind of just reduced.
It has reduced. How much is it seeming right now?
Maybe just, if I think about it, then maybe a 3 or a 4.
Okay.
Yeah.
So what you're saying is that it felt like you had some control, that you can go back to the flow and you can come back to the stomach sensation and go back to that and that. So to be able to move between these two gave you a sense of what?
It was very new. I think it gave me some kind of a anchor that I can do something about this, at least inside me.
I can do something. It's a sense of control a little.
Yeah.
Right?
Yeah.
Oh. All right. So pausing here with Nancy. So what we did here was, first technique was resourcing. The second was titration, which may happen. So here the sensation, sometimes, maybe a sensation may be like a tightness in the jaw. Or sometimes people may say, I can feel my shoulders scrunched up. So what we may do is, you notice it here like this. Can you open it a little bit? Then you again close it, you open it, you close it and open it and close it more and open it more. So you can do titration again. Titration gives people the sense that it's not stuck. Nothing is stuck. It can move, because things may feel stuck for a long, long, long time for people who have undergone trauma. So we have not discussed the childhood history of this client. Both parents were emotionally very unavailable. Mother was very minimally available. So there was trauma a lot in terms of emotional neglect more than anything else. Am I right? Right? So she was banking so much upon the marriage that she even calls her husband dad or daddy or something, right? So she says that I used to look up to him almost like a father figure. So when there was so much investment in the marriage, but now he's seeing another woman, it is disturbing for anyone, you know, no matter whether they've had childhood trauma or not. Of course, it would be very disturbing for anyone, but it becomes even more disturbing for someone. So this is like insult over injury kind of a thing. That there's already childhood emotional neglect, and now she's feeling even more lost, and she doesn't have anyone hoping to rely. So so maybe one more thing that I can mention here is there's one model given by Price, Price, and who talks about, it's a very interesting model, who talks about 3 kinds of boards, BOARD board, 3 kinds of boards. First is surf board. So we all must be aware of this window of tolerance concept, that in the middle there is a window of tolerance in which we are able to think and feel at the same time. We are feeling balanced enough, we are feeling attentive enough, we are able to do whatever we need to do. Or we may be hyper aroused, that we are very anxious or very hyper vigilant, or we may have a very fast startle reaction, and we are feeling lack of emotional safety. Or we may be feeling hypo aroused, in which we may be feeling very zoned out or shut down or flat or numb, and it's difficult to think. We may be switched off. We may sometimes people report very severe symptoms that right now I can't see, or right now I can't feel one part of my body. Different depersonalization, derealization symptoms. And a lot of the going on with abusive relationships happens because the person is hypo aroused. So surfboard is just the concept that surfboard, like surfboard, we all know surfing people do on the sea. So if someone is on the surfboard, then they are within the window of tolerance. But if they are hyper aroused or hypo aroused, they have basically kind of gone off the surfboard. So we don't do any analysis or anything that time. First and foremost, the goal is to get back onto the surfboard. So we do different stabilization exercises. So stabilization would be anything, very basic things, again, whatever the deeper structures of the brain need. So muscle relaxation or breathing or just grounding, noticing the contact points with the floor, with the seat, with the backrest. So somatic grounding exercises we do, so that kind of the person comes back on the surfboard and they are feeling again more or less safe. The second kind of board is the keyboard. So keyboard in which one or the other key is stuck. So either they are not feeling a particular emotion, or they only keep feeling that emotion, whether it is anger or anxiety or anything, or they can't feel a particular sensation, or they are only feeling. So some people report, I have constant leg pain, and we know about somatoform disorders that people may have different pains all the time, while there may not be any medical cause to that. So any emotion or sensation or thought or anything which is stuck. So like a keyboard, one of the keys is stuck in either constantly being on or constantly being off. Either it is not at all functioning, or it is only going on typing or playing the same note. So the second kind of board, that is keyboard, if that is happening, that one thing is stuck, then we may work with maybe healing that and getting that unstuck more than doing any analysis. The third kind of board is the boardroom, B-O-A-R-D, boardroom, which acknowledges the presence of dissociation, and that there are multiple parts. Ego state therapy also, we are aware of transactional analysis kind of a thing, in which there is a parent part, child part, adult part. So there can be many more parts in people with severe dissociation. So the role of boardroom would be to talk to all the parts who are there and not make any part feel wrong. So so right now what we were doing was when she's feeling very insecure. So right now she's, maybe because she's playing the role of a client, she's not a real client, she's more or less stable. But if the client is feeling very unstable, then we will first do something to stabilize the client, and we will not do any other intervention. When the client is stable, we can even do some amount of cognitive work. So I'm wondering, we can maybe pause or stop and take questions, because it was a very brief demo. I'm sure people may have lots of questions.
I think we can continue, and in the end we can take questions.
Okay, fine.
Quite good.
All right, fine. So I am wondering if we can do maybe a little bit of some amount of inner child work. Mhm. Okay. So are you feeling okay, Nancy?
Yeah, I'm feeling a little better now. Yeah.
Okay. So Nancy, I'm wondering that, when you've told me different experiences in your childhood when you were not feeling very emotionally seen, like both parents were busier with other things, and you did not feel your emotions held enough. So if you can bring any one image to your mind when the little Nancy is feeling a little lonely, if you have any one image, take something which is not too disturbing right now.
Mm. Yeah, I mean, I think I remember most of the time sort of just sitting at the doorstep of my house
Mhm,
by myself when I was little.
mhm,
My mom was a little busy always. She had a lot of children to raise. She had 4 of us. My dad wasn't home much. Since I was the youngest, my sisters didn't include me too much. They thought I was too
mhm,
young for something. So I kind of remember just sitting by myself
mhm.
a lot of
What age do you see yourself in this image?
maybe. I mean, I did this for many years, so I can see myself at many ages.
Mhm.
Maybe the first thing that came to my mind was 8 or 9.
8 or 9. All right. So, what is the emotion you are feeling towards this 8 or 9-year-old Nancy?
What I feel when I look at her now.
When you're looking at this image of the 8 or 9-year-old Nancy right now, what emotion do you feel towards her?
I feel sad for her.
You feel sad. Okay. Do you think she's aware of your presence?
Not really. I mean, just looking at her from behind, I don't think she
From
can
behind. Okay.
see me.
Do you think she would feel safe if she was to know that you're there?
I think she would. She wants some company. I don't think she
She
will.
wants some company. Okay. She would feel safe with your presence.
Yeah.
Okay. So is it possible to imagine moving in front of her?
Yes, I can.
And would you want to kneel down to her eye level so she can see you more clearly?
Mm.
Is she
Yeah.
aware now of your presence?
Yeah.
Okay. And is she feeling safe to have you around?
Mm. Yeah. She's
Okay.
just getting to see me, getting to know me.
All right. So can you ask her, say your hello to her, tell her that you would really like to know what she's thinking and feeling. How does she respond?
She's happy someone's asking her this.
Okay, and what does she tell you? What is she thinking and feeling?
I think she's just a little like upset. She's feeling a little alone.
Feeling lonely and anxious, is that?
Yeah, she's feeling a little upset.
Upset. Tell her you would really like to be there for her. And would she like to tell you what she needs?
Hmm. Yeah, I think what she wants is probably just go out of the house sometime.
Like to go out of the house? Okay. Would she feel safe to go out of the house with you?
Yeah,
Does she know where she wants to go, or would she want to do that?
I think there's one park that used to be close to our house.
Mhm.
I think she just probably wants to go there and play. And she didn't
Okay.
really get to do it much. I think she
She didn't
wants
get
to
to
do
do that much. She wants to do that now.
Yeah.
All right. So would she want to hold your hand or walk by herself? Or would she want you to pick her up in your lap?
Yeah, I think if I give her the option, she'll want me to carry her and go.
All right. So you can carry her
Mm.
and walk from there step by step, step by step. Keep walking till you reach the park. And what would she want to play?
Mhm. She's very excited. She's finding it hard to choose, but I think she's going to go for the swing.
She would like to go for the swing. So is it okay for you to be there with her on the swing?
Yeah.
And tell her she can choose all the things that she wants. There's no hurry. She can play everything that she wants.
Mm.
And you was her playing on the swing.
Yeah.
Whenever she's done with that, what would she like to do next? She can play, she can tell you anything, she can sit quietly beside you, she can walk around with you.
I think she wants to walk around.
Okay. All right. You can walk around with her as long as you want. And you can even ask her after the walk, would she like to come with you? Would she like to go back there? Would she like to be dropped anywhere else?
I think she might be okay to stay in the prayer room
In the prayer room,
in our church. Yeah.
in the church. So let her take all the time to play. You continue to imagine that while I tell the audience that we might take a long time to do that. After she has done that, whenever she is ready with that, then we will say that you can take her to the church whenever she wants.
Yeah. She's comfortable there in the church.
Okay. What does she feel?
She's feeling safe. She likes the wall. She likes the carpet on the floor.
Mhm.
She has a habit of rubbing the carpet with her fingers. She's doing that. She likes it.
And she used to anyway feel very safe by praying, so she's feeling that safety.
Yeah.
Okay. I want you to tell her that you're always there. And that you accept her just as she is.
Yeah.
And that you love her no matter what. And that it makes you feel very happy to do things that make her happy. What are you noticing?
She's happy. She's hugging me.
She's hugging you. So to the audience, we might again ask her if she's okay to stay in the prayer room or would she want to come back with the adult. And even though she has said earlier that she would like to stay in the prayer room, we will not stop this exercise without again checking with her. So let her take that time that she wants. And after that, now what would she want? Feel safe to stay all alone there in the prayer room. She'll come back with you and go with you as many times as she wants.
No, I think she wants to stay there. She feels
Okay, fine.
safe there. Yeah. She doesn't
Alright.
feel alone.
She doesn't feel alone. All right. So you can come back here with us now whenever you want, whenever she's safe. Let you come back. What are you feeling right now?
Yeah, I feel quite relieved and happy that she's in a place where she wants to be.
Okay. All right. Okay, so we will stop the demo right now. This last demo that we did was not connected to the first demo that we were doing, but I was just showing that there are different techniques. And this second exercise that we did is coming from the belief in dissociation, that there is dissociation. It's also connecting to the attachment work that, and it's also connecting to neuroplasticity, that there are ways to heal the neuronal changes in a better way even now. Guided imagery is a very commonly used technique, whether we create different resources or we do this inner child work or ego state work. Guided imagery really works. As you saw, I didn't have to guide too much. I had to just let her do the work. I was only asking her questions. I'm sure there may be lots and lots of questions, and I hope it's not confusing. So is it okay to stop the demo now?
Yeah, sure, ma'am. We can stop.
Yes. Thanks a lot, Ashwati. Thank you so much.
Thank you.
That was absolutely amazing demonstration, madam. Thank you so much.
Thank you.
Actually, that was how a demo should be done. So on a different note, it was how it should be conducted. For excellent that no one is, yeah. Thank you so much, ma'am. Thank you so much.
Thank
Any comments from the chairpersons? Then we can start the question answers. There was a query. We start with the demo. Suppose the client opens eyes in between in this inner child work.
No problem. We will say you can keep your eyes open or closed. Even if you want to keep your eyes open, you can. Some people are very scared to close their eyes. Closing eyes might have been very scary in their life experiences. So we never force anyone to close their eyes. Usually people will close eyes because it's easier to imagine anything with eyes closed. But if someone doesn't want to close, we never say close your eyes. And we just give them all the options. Sometimes we say, if you want, you can look at any one point down so that you're not too distracted by everything else around.
I think there's a question. How good is the evidence of these techniques in Indian population? I would like to just reframe it more. In which set of population these techniques works better, madam?
So our everyday clients, all these techniques work with people with anxiety and depression and personality disorders. At least we can definitely use most of these things. We will use different things depending upon whether we are whether the client is stabilized or not. If the client is not stabilized, we will first do stabilization. So we'll do different techniques. But our everyday clients, all the neurotic disorders and personality disorders, we can definitely use all of these.
Yeah. In fact, when we were structuring the program, we discussed that we will take a very normal sort of situation, a very average, usual scenario that we see in the clinic. So I think this is a very usual thing that one bad experience on other past experiences. So it is a very, I think, appropriate case for day-to-day workup. So, ma'am, in the first part of demo, you demonstrated what I could gather was the output was this sense of control between the flow and between the sensations. So the patient was able to switch in between. What happens otherwise? If we are not doing this therapy, if we had not intervened, what would actually be going on in the patient?
So people become the keyboard. So the feeling in the stomach of pulling something down, that keyboard key will get stuck. They will keep feeling only that. Then people may develop different disorders also, IBS and all that. So with all gastrointestinal disorders, trauma is very, very highly implicated. So that may happen. And people start feeling scared. So as we know, our vagus nerve, no, the 10th of the 12 cranial nerves, is the longest nerve in the body, and most of this nerve is afferent. So it takes information from different organs to the brain. So if someone is feeling this pulling down sensation in the stomach, they will feel a lot of tension, a lot of stress, a lot of things in the mind. So that is what would happen. So pendulation basically is just the normal data. So our heart also is pendulating, our breath is pendulating, our sleep-wake cycle is pendulating. So everything has an ebb and flow. So pendulation is basically just to simulate all the natural procedures. A bird's wings are closing and opening. So pendulation helps the client to, so there's no denial happening. Don't think about that disturbing situation, just keep thinking about the flow. So that toxic positivity is very harmful, in fact. So people keep trying to think of that I should not feel that should starts happening, that I should feel only the positive sensations. Pendulation respects this and respects this. So it is respecting both. You're allowing to stay in the flow of both rather than think only the disturbing situation or think only the positive.
So we are accepting the situation and then we are able to move about, be
Yes.
more mobile.
Yeah, but I never said accept it or anything. We don't give instructions. It is just in the way that it is done that it becomes accepting. That when I'm looking, so most people would not look at the disturbing thoughts or situations or sensations because they think that would be so scary. if I think of that, then I will keep thinking about that. That is the fear. So when we are aware of that and aware of a quote unquote positive sensation, and they are able to flow between the two, then it becomes easier for them to look at.
So, ma'am, any other alternate way of this pendulation or reaching to this?
Yeah. Pendulation, you can also do like I was demonstrating if the jaw is tightened. That I have a client who has this constant frown here. Constant frown. So I say frown more and more and more, and then relax. A little bit like JPMR, but not exactly JPMR. So you make it tighter and you make it loose. You make it tighter. So you do it several times. So the thing which was like the keyboard key was stuck. So it feels unstuck. Shoulders, most people have shoulder pain, at least my clients, many of them have shoulder pains if we ask them. So I didn't cover so many things, when we are taking trauma history, it also helps to take history about any chronic pains among all our clients who are visiting psychiatrists and psychologists. So many of them have chronic pain, so many of them have digestive issues. So when we take that, so if they have say tight shoulders, you can do this. Many of them, so you also can connect. So suppose this inner child work that we did, instead of that, we could also do when she is sitting alone at the doorstep. So like pantomime, so if she could enact, if her body could enact, what does it look like? Does it look like this? 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 So whatever it looks like. So suppose it looks like this. So you first start with that, whatever the emotion is being somatically communicated as, and then you do the opposite of that. So opposite of that would be, say, opening out like. So you again come back to that and again open out. You again come back to that, again open out. Suppose it is very difficult for the person to open up. Then you start with little bit of opening, then you open more and more and more.
Okay. Ma'am, in the second part, you did the inner child work. What are other things that are done in parallel to that or comparable to that?
Meaning?
Meaning, do we have any alternates of this, or this is the basic thing that is done?
No, there are many things. See, what I did was I worked with dissociation. But she's an adult. She's right now here. That is one part. One part she can visualize sitting. It's a whatever 8-9-year-old, 6-7, whatever age she said, is sitting at the doorstep. So that is one part. Now what we are trying to do is we have tried to do a little bit of integration of these two parts. That this part can go to that part and help that part and maybe bring that part wherever. So 2-3 things are happening. One is that part was feeling stuck there. People will have repeated flashes, or repeatedly they would report also, I cried myself to sleep every night, or I was crying alone on the terrace. Nobody knew where I was, or I was doing this. So that is a stuck memory. The keyboard key is stuck. So when you do this kind of integration work, you're helping the image get unstuck. You brought it here. But what are the different methods? There is internal family systems therapy, which is also parts-based work. There is ego state therapy. Inner child work is from ego state therapy. And there are different ways of working with parts. So this was one of the many ways of working with parts.
Yeah, some questions on the chat box. Many people have asked, it seems similar like EMDR, similar like self-hypnosis or ERP or maybe JPMR. So how similar, how different is trauma therapy from all these other therapies and CBT?
So it is very different from CBT. So because this group has gone through at least 3 lectures, I didn't give too many lectures, but we talked about 2 different kinds. All the psychotherapy approaches can be divided into top-down and bottom-up approaches. So top-down, so the same brain model. So top-down means you start from thought. Why do you think this? Why do you feel that? What are you thinking? What are you feeling? So all those questions we are addressing to the higher brain part, which is the language is also here. When we do somatic work, we did somatic work here. Somatic work, we are doing bottom up. So we are starting from the somatic technique. and then it would get, so when she was able to put it in words, I feel more control. That the higher brain is able to make sense of that, make meaning of that. So how is it different? So trauma therapy, so we do use little bit of CBT also, but CBT alone does not help in healing trauma is the point. So we need to do a lot of bottom-up work, and then we can do a little bit of top-down work. How is it different from EMDR? It's not different from EMDR. EMDR is one of the many trauma therapies. How is it different from JPMR? JPMR is one of the relaxation techniques. Relaxation would be an integral part of the initial stage of trauma therapy in which stabilization has to be done. So you may do the whole JPMR, but sometimes even meditation, even yoga. So sometimes people think, I have done meditation in the morning, so now why am I stressed? Now I have even yoga teachers as my clients. So what happens is that only doing it for half an hour or 1 hour in the day and the whole rest of the day, our breath is tight, our muscles are tight, it will not help. So what we have to do is we have to kind of sprinkle is like salt and pepper in the whole day's experience. And that is why doing little JPMR kind of things, even this you can think it's like JPMR, tightening and loosening, tightening and loosening. But if someone has already done JPMR, still their muscles are tight, doing it in the moment when they are thinking about the memory, their muscles become tight and then you loosen it. Then if they again think about the memory, muscles get tight, then you again loosen it. So when you pair it with that memory, it always used to make their muscles tight. Then that time you are loosening that particular memory, it also gives them a little bit of sense of control.
Thank you, madam. One question that has come in the chat box is, what happens if we can't identify the trauma, but we know that something disturbing has occurred in the client's life? Now we are not able to identify the trauma. So what happens?
So trauma assessment has to be done with everyone. With every patient, we have to do trauma assessment. But we don't do trauma assessment right in the beginning. Okay, tell me all the abuse has happened to you, all the neglect has happened to you. That would be re-traumatizing. So when I said one of the principles of trauma therapy is safety. So we don't bombard the client with questions about trauma. We first have to take, of course, when the client comes, they will say, this has happened, that has happened. So we take a little bit of that, but we first empower the client with stabilization techniques. And then we take more detailed trauma history. So, one of the things about trauma therapy is people think that we will keep using the word trauma in the session. That is not at all what happens. In the session that we saw, I think not even once I used the word trauma. In fact, when we talk about ACEs, adverse childhood experiences, which I'm sure this group knows about, which are 10 ACEs, which are internationally approved, and even in India, the scale has been validated. So when ACEs are there on the one hand, so if you imagine a weighing scale, and on the other, there are positive childhood experiences. So why some clients are more traumatized than others, even if the same negative experiences have happened, is because there are very less positive childhood experiences. There are very few buffering factors. There were very few safe figures. There were very few loving people around them. So very few positive experiences. So what we try to do is sometimes, instead of working with the traumatic experiences, we reinforce the positive experiences. So we create safety figures, we create protective figures, wise figures, and loving figures. So we do various resourcing things, so resources become relatively more than the trauma. So then it becomes also easier to process the trauma.
Another two important question, madam, I want to ask. Where can this inner child work go wrong? And what resources should the client have for one to initiate his child work? And another question also in terms of what might happen if somebody dissociates during the whole process.
So that can happen. So when we are working with clients with very severe trauma, then dissociation is likely to happen. So a trauma therapist has to learn to work with dissociation. So what we have to know is we have to know a lot of grounding techniques. Yes. Lots and lots of grounding techniques. So we can ask the client, are you here? Sometimes they will say, I can't. There is one client who one of my supervisees told me that the client says, I can't even see you right now on the screen. So that much dissociation is happening. So you can ask, okay, are you able to hear me? So one sense modality is, so she said, yeah, I can hear you. So then you stay with that sensory modality and you enhance that. Okay, so can you hear? So I will say, you can say, I'll say a number. Can you repeat after me? So you say 5, and can they repeat 5? Can you say 4? Then they can repeat. So you say different random numbers, can they repeat? Then you can ask, okay, can you touch? So you see now sensory modality is working. So when dissociation happens, there are ways to come back to the present. And how can inner child work go wrong? Well, till now, it has never gone wrong. See, one of the things that I can say is that trauma therapy is much lesser about techniques. Even though I was trying to demonstrate a few techniques, we talk about doing therapy and being therapy. So trauma therapy is much more about being therapy. So all these things which we did in the session, I have to be very, very attuned to the client. If I'm sitting, okay, now you do your inner child work, I'll just come back. That won't work. That can go wrong. So when we are looking at attachment work, that we have to do slowly corrective emotional experiences through which the client will have a little more sense of safety, and they will be able to feel like, the core beliefs in CBT that we talk about, the world is unsafe, or nobody can help me. So those core beliefs slowly actually start changing if we are very attuned being therapist, and not just thinking, okay, this technique, we have done all the trauma therapy techniques, it is still not working. Inner child work does not go wrong if we are a being therapist. It can go wrong if we are just doing it as a technique, even if we are reading a script from a book and just doing it.
Okay. Ma'am, have you had experiences where patient became dependent on you, or they start bothering you?
Yeah. So this is a very common fear that all of us mental health professionals have, that the client will become very dependent on me. Sometimes even clients have this fear that, I don't want to become dependent on you. So how we look at it is that the word dependence is, it's almost like addiction. So nobody becomes addicted to us, but yes, people will become dependent on us. And I think there is nothing to be so scared about unless, somebody is being obscene. So we do have very clear boundaries. Having clearly stated rules and boundaries, and first we stick to them, and then the client is expected to stick to them. Usually it works very well. That, we have a clear, I usually keep one fixed slot for that client every week. So, suppose someone has Thursday 9:30 a.m. They are able to spend the whole rest of the 6 days thinking, okay, Thursday 9:30 a.m. will come. So having that predictability, sense of safety, that that framework is very predictable, and so we don't have to cancel the sessions last minute ever, or if possible, don't cancel at all unless. So many things are done. If we are able to create a predictable, healthy structure, usually clients will not become dependent on us, because if you also have rules about whether they can contact us in the middle of 2 sessions or not, and how and when, usually it doesn't happen.
Any homework do you give to the clients?
Homework is usually discouraged in trauma therapy. The reason is that trauma is one of the things which usually people have with trauma is a sense of loneliness while growing up. So when there was loneliness while growing up, if we give them homework, okay, now I've taught you mindfulness, you go and do mindfulness. The client will feel so guilty that they can't do it, and it will again become like a parental situation or a teacher situation in which they didn't do the homework and they're feeling guilty. Secondly, when we are believing in neurobiology that the trauma resides in much younger parts of the brain, the younger parts which would much rather benefit from hand-holding in the session many times, and then eventually people are able to do the homework on their own.
Okay, thank you. Ma'am, what is its role in sort of acute or recent traumas?
Recent traumas are the easiest to heal. because if we are assuming that there is no childhood trauma, which usually doesn't happen, but if there is no childhood trauma, recent traumas are the easiest to heal.
So, ma'am, how the same process is followed, or anything different?
So you can use, we use EMDR, we use somatic work, we use IFS, any parts work, internal family systems, or ego state therapy. Recent traumas are the easiest to heal.
Okay. Okay. Ma'am, what is the broad structure? What is the range?
Number of sessions.
The number of sessions, duration of session.
Duration of sessions is typically 50 minutes. If we know that we are going to do something longer, then we pre-plan it as a 90-minute session.
Okay.
But
And
we decide the duration and we finish it on time.
okay. Ma'am, how do we judge the success of therapy? How do we devise that the therapy is successful, and what is your experience with this therapy?
So clients will come and tell you. Just 2-3 weeks back, I have terminated therapy with the client after 2 years of regular therapy. So duration answer is roughly that. If there is child, so we believe that most of the trauma is childhood trauma. So the word trauma started getting used with war veterans and PTSD, and only recently we have started talking about complex PTSD. But even with war veterans, it is said that many people go for war, and out of that, very few develop PTSD. And when they have tried to do some longitudinal study, very little, but case study based, what they found was those who have not had childhood trauma are very less likely to develop PTSD, whereas those who had childhood trauma would be more likely. Now, to come back to your question, how long it takes longer because we are healing the childhood trauma, which is like long standing and behavior patterns are there and whatever. So how we would know? The client will come and tell you, I feel like a different person. They would say their spouse would come and tell you or message you that, you have not healed just that person. Our entire family is healed and things like that. Or they would tell you that I am sleeping better. So all the usual pointers that we have, they're sleeping better, they're not bombarded with those thoughts, their work functioning improves, their boundaries become healthier. Some of them who were in abusive relationships are able to leave that relationship and either be alone or eventually find healthier relationships, and all the usual markers are there. I know it may sound like a bit of, as almost like an advertisement, but I'm also rather new in this field. 8 years is a very short time. But for me, in the whole history of my working as a therapist of some 29 years or so, 8 years is a very short time. And I have seen a very marked difference when I'm using these trauma-informed methods.
Okay. But there is a question whether you're using complex PTSD.
What is complex PTSD? Sorry, I didn't get the first part.
Can we use the same for complex PTSD?
Yeah, this is what I have said is all about complex PTSD.
Yeah. And how do we deal with children?
How do we deal with children? I don't typically work with children, but with children, we have lots of trauma-informed play therapy methods, trauma-informed art methods. And a lot of the work with working with children would also be to work with parents and improving their parenting style.
Okay, Amrit.
अब अमृत क्या है सारा क्वेश्चन पूछने का अमृत madam, last question, then I will wind it up. How do you find your this therapy with regards to rural population, the illiterate people, and so people who are not so psychologically sophisticated? What is your experience with them?
So there is very little use of some jargon or anything, so illiterate doesn't matter. I work with lots of people who are Hindi speaking. I have very few maybe equal number of English speaking and Hindi speaking people. So that doesn't make any difference. And rural population doesn't usually go for therapy, I think, to all of us. So they don't come too much to me also. So I don't know much.
So thank you, madam. We'll call you again. It was really nice. So we'll hand it over to the chairperson. Otherwise, Alim will keep on asking questions and questions and questions.
I'm quite now. Satish boss. You can unmute.
Satish boss, we wanted to mute Alim, not you. So please unmute yourself.
Thank you, ma'am, for such an excellent and wonderful presentation. And it was such a very live demonstrations, and it was such a very, very interactive session also. And though we have learned today, in today's session, we have learned a lot about trauma. So because like as you mentioned that the trauma, so early childhood experience, there's a link between early childhood experience and like in the developmental milestone, and it does affect how it affects our normal brain development, and not only brain development, also the epigenesis, which is actually it does something to the DNA, and that the scar which which led by early childhood experience, it lies not only in your mind but also in your body, and that's why the role of somatic therapy comes into play. So, and also you mentioned about the dissociation, which is the disintegration of the mental faculty when somebody is traumatized by their own people, because it's very hard to accept for the small child to accept the fact that most of the time the traumas which are being done by their, especially their family members, not strangers. That's why in order to prevent the anxieties arising out of them, in order to protect themselves, in order to feel themselves, the people go into dissociative state, and they develop all kinds of mental disorders. So I feel that as you say, the screening is very important, but it is so the timing of screening and timing of asking the questions also important. During a clinical practice, it is first we need to wait for time, and only after a few sessions with the client we need to start asking about traumatic experiences, because we should refrain from poking too early during interactive sessions. And the phases which we have mentioned, that now we have to stay the stabilization phase, then trauma processing by various somatic resourcing and other resource materials, very important. And at last, integrations by doing the inner childhood work, so that so the integration of mental faculty in order to make the help the client is very, very important. So very and I also felt that as you mentioned, so the therapies, there's so many therapies were coming, like acute related with mindfulness meditation, JPMR, then somatic therapy. So in traumatic therapy, so therapists, we have to try different method as per the symptoms, as per the problems of the patients, as from the new symptoms, new patients, as per the experiences. So there is no single therapy. So we have instead we have to try different methods and strategy to help the client. Thank you once again, Madam, for such a very, very enlightening these presentations, and thank you to the Thursday Masing, Dr. Tupan sir, Dr. Alim, Dr. Amit sir, for organizing such a very, very beautiful session, wonderful session. So we hope that we are learning so much from Thursday, these sessions, especially in psychiatry and psychology. And we hope that Madam will be invited again in this session to empower us, all of us. Thank you very much.
Thank you so much, boss. Tufan sir.
To Dr. Tushar.
Sir, Tushar sir had to leave. He had a meeting, so he has just.
Okay, nice. So I have got a very simple inquisition. Dr. Sadini needed 6 sessions to interview Nancy as she interviewed today. How much time does it take? Number 1. Okay, I am giving the second part. And all the innovations like childhood trauma assessment, stabilization, and relaxation, the pendulum relaxation processes, it must be requiring a specific trauma therapy training. In the background of all this, where we started interviewing Nancy today, Dr. Ashwini today, so how much time it will take, and how can we really integrate to have a trauma lens in general clinical practice? The time constant part mostly.
I want to briefly request Ashwati to respond to that. She has recently attended a trauma therapy training, and I want to ask her if she feels, if she wants to respond to any of this.
Yes, ma'am. I think taking on the trauma lens doesn't take very long. I think once we are well informed about the principles that ma'am used to keep repeating in our classes, and also just understanding the actual conceptualization behind the case, it barely takes few minutes. Even if you just see the client walking into the session, it's a wealth of information. So in terms of time, I think that it's not a very time consuming process in order to understand for us. But it absolutely depends on the client, when to take it, how far to take it, and how stable they are feeling. All of those things is a process. It isn't like ma'am was saying. It's not a very doing based therapy. It's a being thing. So it's a very collaborative process that we base with the client. But I think in terms of our understanding, it's very limited in terms of time. If we grasp it, I think it's very useful. It's incredibly useful with clients to just start applying it.
Thank you, Ashwati.
Well, thank you.
Also, when you asked the question that it took me 6 sessions to interview Nancy, actually 6 sessions is nothing. With some clients, I have been doing very regular 1.5 year long therapy once a week. And so when we believe in dissociation, what happens is that many things people don't remember. It's not like they have forgotten. It's not like amnesia, but it's not there available in the most top layer of conscious mind. So they would keep telling us new things after even 1.5 to 2 years. So it's not like in one go we have finished the interview and we have all the history and we have all the traumas that we need to work with. So it would be in layers, that as many things keep getting healed, people would be able to open a new layer. Not that they don't want to tell. Sometimes they may not want to tell us, but many times they are unable to tell us before that.
Thank you so much. Amrit,
Thank you. Thanks.
So
Thank you. Okay, Amrit.
thank you, Shalini madam. It was really wonderful. Ashwati ma'am, you also did a wonderful job. It was the absolute demo. That's what we always discuss. That's how a demonstration should be. And you covered a lot of questions, lot of answers. Satish boss was wonderful again. Tushar sir, thank you so much. He could not come till the end. Tufan sir, thank you for the last bit. A lot of people had those thoughts in their mind that how long it should be, how is it easy it is. So thank you so much again. Halim, as usual, he'll play the maximum balls and try to score the maximum runs. So thank you so much, everybody. It was really something where we learned a lot of things. Easy techniques, not too many jargons. People run away. Many of us run away when we hear those things. So it was very, very simple things which we do maybe in a better way. And it was really a Thursday musings night where we learned a lot of things. We would again be happy to have you again if you agree to us. Maybe in the next couple of months, we'll again call you, madam. There's one question that I want to ask before I stop this. Where can they get this training? A lot of people have been asking me and putting in me personal messages that
how to contact?
where can they get this training?
So there are different specific techniques trainings which people can get. Internal family systems therapy training happens only in the US, and there is like a wait list for that. EMDR training is happening in India also. There is an overall trauma therapy training which I conduct. It's a course which recently I completed, in which Ashwati was one of the students. It was a 30-hour course. So I do it at least twice in a year. And so if anyone wants, they can learn with me.
Give your email ID, madam. People want to contact you in the chat box, madam.
Yeah, sure.
And with that, I would also like to thank our audience. They're always a dedicated audience. We're more than 300 people who had logged in, 320 or 325. So we had a peak of, and that's really wonderful on a Thursday. Thank you, Torrent, for being at the back end. Thank you, Sazia, Rucha, and Sharda also. They gave us all the inputs about madam. We spoke a lot about madam, and then we could get her in. So
yeah, ma'am has posted her email ID. Please contact her and get yourself trained.
Thank you so much. Thank you, madam.
Good Thank night. You so much.
Good night.
Good night.
Thank you, everybody. Good night.
Good night.
Good night.
Really wonderful session. Really wonderful. Worth it. Thank you.
Thank you, ma'am.
Thank you.
Sir, can we close the session now? With your
Yeah, we
permission?
should close. Yeah. Let us close.
Okay.
Yeah.